A very good afternoon, everybody, to the latest in our series of inaugural lectures. For people that don't know me, my name's Phil Baker. I'm Pro-Vice Chancellor, Head of College and Dean of Medicine. And although this is the latest in our series of inaugural lectures, it's the first one that we've tried to progress digitally rather than having all of us in the same lecture theatre. And I have to say, I would much rather be with you than doing this in a remote fashion, but this is the new normal, and we have to get used to adapting our academic life. So let's celebrate our inaugural lecture as much as we can, even though we're not actually all sitting together. You'll notice that we are gowned, and I wasn't sure whether we'd be gowned for this distance, but when I arrived and saw my colleagues gowned, I thought, right, the reason that we do our inaugural lectures gowned goes back to medieval times, when the inaugural professor would come and deliver their lecture, and at the end they would turn their back upon the audience, and each of us would go up and put an I or a nay in the academic hood. We'd then tally the votes and determine whether or not the inaugural lecturer had reached the requisite standard to be admitted to the academy. Well, despite the fact that our inaugural lecturer, Professor West, will be wearing her hood, we won't unfortunately be able to put her through that ordeal this afternoon. I'm going to hand over very shortly to Richard Holland, the head of Leicester Medical School. But before I do, I just wanted to add my personal congratulations to Judith, who is, I would describe her as just an outstanding academic and member of our college. The title of her lecture is "What Makes a Good Doctor," and some would say that there's very few people better qualified to answer that question than Judith herself. As a very prominent doctor in our community, as a leading senior manager in one of our partner trusts, and not least as deputy head of our successful medical school. There can be few who deserve the accolade of promotion to professor more than Judith. So without more ado, my congratulations, Judith. I'm very much looking forward to hearing your lecture, but I'm now going to pass on to my colleague, Richard Holland, head of Leicester Medical School. Over to you, Richard.
Thank you very much, Phil. Huge welcome to everybody here. I feel very honoured to introduce Judith to you. Judith's been my deputy head of school since I took on this role, and she's done a fantastic job. I'll tell you a little bit about Judith. She trained in Birmingham, qualifying in medicine back in 1983, and undertook specialist training in paediatrics, including paediatric respiratory medicine, throughout the Midlands, but also in Bristol and over in Australia in the Royal Children's Hospital in Melbourne. Judith then worked as a consultant community paediatrician in Leicester from 1996, was awarded her MD in 1997 for research into lung infection and immune responses in young cystic fibrosis children. Judith held senior educational roles at the medical school as our head of students and staff support, where she was responsible for professional development and coordinated medical student support throughout the course. More recently, as I said, she became my deputy head of school back in 2017. Judith was also Associate Medical Director for Medical Education at Leicestershire Partnership Trust from 2015 to 2020, supporting a wide variety of junior doctors from foundation trainees to primary care doctors, psychiatric and community paediatric trainees together. Judith was instrumental throughout that time in securing really strong collaboration between the University of Leicester on the one hand and the Partnership Trust on the other. She also successfully steered LPT through two quite demanding quality assurance visits by Health Education England, East Midlands, with very, very good feedback at the end of those. Judith is undoubtedly an inspirational leader for our students. She regularly receives commendations from them, and just as importantly, she provides great support to my academic colleagues, quietly but highly effectively providing support both formally and informally to female academic colleagues within our school, and thereby very genuinely promoting our Athena Swan agenda, notably through her Women in Leadership discussion group and action learning set. Judith is an outstanding colleague and an educational leader. Her wise advice to me, but also my team, is vital in helping steer the school successfully through our many challenges, but also our many successes. Her quiet and unassuming manner actually belies her undoubted pedagogical excellence. She operates extremely effectively at the very highest level and is a genuine asset to the university. I've been looking forward to do this inaugural lecture at Judith for many, many, many months. So this is long awaited. Judith, welcome to your inaugural talk, and I'm thoroughly looking forward to the next hour. Thank you.
Thank you very much. Thank you, Phil, and thank you, Richard, for those kind words. Hello, everybody, and welcome to my family, friends, colleagues and students, and thank you, everybody, for your support. So I think I'm going to switch over to slides now and start my lecture. So thank you for taking the time to attend my inaugural lecture on the subject of what makes a good doctor. In this lecture, I will describe using 4 personal stories, introduced by music, how I've applied my values and insights on my experience as a paediatrician in a medical education context to prepare medical students to become good doctors, capable of not only surviving, but thriving in the NHS workplace. What do we mean then when we refer to an individual as a good doctor? The General Medical Council defines a collection of professional behaviours and competencies that can be described, measured, and if necessary enforced through regulation. The public has a high level of trust in doctors and rightly expect that doctors are fully trained to be competent and safe practitioners. But we also expect doctors to act with integrity, to be both morally and socially good. So do we as clinicians, as educators, as students, as patients, just know a good doctor when we see it? In the same way that doctors describe eyeballing a patient, a skill that's taught early on in medical training and is invaluable to us all, whether as a junior doctor or as a senior consultant. That art of the rapid visual assessment to gain insight into the patient's condition. Tuesday morning, and as usual, an overbooked paediatric clinic awaited me. As I walked in, I noticed a distressed mom with her 2 children at the reception desk, asking if they could be seen by a doctor. It wasn't long before Margaret, the clinic nurse, armed with a strong cup of coffee, was in my clinic room, asking any chance you could see those 2 in reception quickly. They're off the traveller site down the road at Castle Donington. Not sure there's much wrong, to be honest, but Mum was making a bit of a scene, and it's upsetting the elderly patients. I knew from previous experience that local travelling families would occasionally arrive at Culver Hospital on the off chance and without an appointment, and it was unlikely the family was registered with the GP. I also knew that travellers did not generally trust health professionals, and it would have taken a genuine concern to bring her here. I was curious, and so agreed to see them. So these 2 children then, aged 4 and 7, let's call them Charity and John, were, according to Mum, just not right. Both were reported to have vague symptoms of tiredness, occasional tummy pains, and were moody. There was little to find on examination. Both children were slightly short for their age, but neither was underweight. I decided to explore Mum's concern through seeking further information from school and from the travelling family's health visitor. I asked Mum to bring the children back to a clinic appointment in 1 month's time. John's teacher reported that he was struggling with literacy and numeracy, although he hadn't been particularly concerned. That's what we might expect. Traveller children often don't do that well academically. The school nurse had been asked to review John as he was newly enrolled at the school and was concerned. I can't put my finger on it, but I think there's something going on. 1 month later in clinic, Mum reluctantly agreed for John and Charity to have a blood test, which showed a microcytic anemia, small red blood cells, and iron deficiency seemed the most likely diagnosis. A week later, I received a call from a registrar in public health. The team had visited the traveller site and there were environmental concerns. The health visitor had noticed that all the children were well cared for, Their parents had engaged well with health advice offered and were not, in her words, your typical traveller children. The children's diets were pretty good, including eggs from the children's kept on the site. I looked back at John and Charity's notes and saw there was something else on John's blood film. Basophilic stippling, small coloured grains that are sometimes observed in young red blood cells when the blood is examined under the microscope, and a sign of disturbed red blood cell production. Fortunately, there was enough of the original blood sample left in the lab to carry out further investigations. So I went on a home visit to the traveller site with the public health team. We arrived at the gates to the site where we were met by several men with large, pretty fierce-looking dogs, and we negotiated through the fence to eventually gain entrance. The site was next to a disused railway line. It was a sunny day, and the children were all playing outside alongside in amongst the disused scrap metal. I think the matriarchs of the families had done a good job to persuade the men that this was important business. We were welcomed into the caravans and given bottomless cups of tea. We were able to take blood from the majority of the children on the site that day, and several more children, like John and Charity, were found to have lead poisoning due to environmental exposure, both from playing out at the site and from eating those contaminated eggs. So what was the outcome for John and Charity? It was clearly in their best interest that the children were moved off the contaminated site. Most families did so and were given temporary local authority housing. But this did come at a cost through fractured relationships within the traveller community and their giving up of traveller heritage to ensure their children's needs were met. The family continued to bring the children to my clinic for annual health review for several years, even after they had left Leicestershire. Paediatricians often triangulate fragments of information to form an objective view of the whole child and the family in the context of their social, educational, and economic environment. For medical students in the audience, this approach is not like a normal OSCE station where the clinical problem to be solved is logically structured and the sources of information are clear from the outset. This professional curiosity, the difference between looking and seeing, while challenging assumptions based on stigma, is important in community-based paediatric practice and is vitally important in child protection work. I applied this clinical diagnostic approach in a medical education context as a means of identifying and monitoring students in whom concerns had been raised regarding either their academic or their professional performance from a range of sources. That might be their tutor, that might be their teacher, that might be the administrative staff, and it might be patients. This is because all UK medical schools are required to ensure that only students who achieve the outcomes set out in GMC Good Outcomes for Graduates, and therefore are fit to practice safely as a doctor, are permitted to graduate. Initially, we identified students causing concern using a codified traffic light process, with referral using professionalism concerns yellow form. But the system was not at all popular with students. There was, of course, talk of being red carded or yellow carded, and I was interested to know why this was such a problem. Students told me that they felt stigmatised by being judged unprofessional, through decisions being made about them rather than with them, and no opportunity to learn from their mistakes. There was anxiety that the label would stay with them for their whole medical career. This student focus group feedback resulted in a real change to our approach, using instead a confidential and supportive multidisciplinary team, the personal and professional concerns group, to assess, support, and provide feedback to a student in difficulty. Importantly, the impact of health issues on professional performance was recognised and managed, with excellent support from our NHS occupational health colleagues. And you will see on this slide that the majority of the work of this group is in referring and acting on opinions from our occupational health colleagues, but also with help from our professional support team led by Mr. Leicestershire Griffiths, who offer a range of tailored professional support interventions to promote reflection on professional attitudes, seen here in red. As a result of this, I believe that we have had less students needed to be referred to our disciplinary processes, and in particular, you'll see in grey that very few students attend our fitness to practice committee, and also fewer students who are needing to take suspension of their studies. It was my first paediatric SHO job, working on the professorial child health unit of a large Midlands teaching hospital, and so I was very keen to make a good impression. Despite this, I was still full of apprehension, but determined not to show it. I was a month or so into my job working on the neonatal intensive care unit, and 12 hours into a 24-hour shift when I was emergency called to labour ward to resuscitate a full-term baby following a traumatic delivery. A much wanted child after mum's 3 previous pregnancies ended in miscarriage. With help from the neonatal nurses, I successfully intubated the infant, let's call him James, and worked through the night without a break to stabilise him. There were hands-on, technically challenging procedures to be undertaken, inserting tubes and lines for fluids and monitoring. But by early morning, James was stable, and all the necessary tests had been organised. The numbers, by which I mean the blood gases and the ventilator settings, all looked good, and I felt a real sense of accomplishment. I took 10 minutes out to snatch a quick shower and a coffee before the professorial ward round, pleased that James was alive as a result of my efforts. Although exhausted, I would be able to present a successful night's work to the boss. What followed on that morning ward round was unexpected, and in my eyes, both an admonishment and a professional humiliation. I was indeed given credit for my technical endeavours. The baby had survived, but what about the longer-term implications for James and his family? The questions came at me thick and fast. Was I right to be saving a life at all costs? Was I avoiding the difficult conversation with the family? Why didn't I call for help? What shocked me was that I'd worked so hard, followed all the rules, but still ended up getting criticised. I was just getting through the night shift as best I could. It was the first time in my medical training that I let my emotions get the better of me, and I felt at fault for showing distress. As a doctor, you're expected to push your feelings to one side and to get on with your work. But I had failed to differentiate between my own emotions and what would be best for my patient. There was a difference between my perception of myself and the opinions and judgments of my colleagues. As a medical trainee, I'd created a protective bubble for myself, which, in that moment, had been burst. So what of James? He made a gradual improvement, spending several more weeks and months on the neonatal unit before discharge home. He has 4-limb cerebral palsy and significant learning disabilities, attends a special school, brings joy and is much loved by his family. His parents were always appreciative of the care and kindness shown by the NHS. Studying medicine is demanding, and medical students are often reluctant to ask for support when they're struggling. At some point in their careers, all doctors will experience feelings of frustration and distress. I would argue that we all live in a bubble which is protective and informs our view of the world. The bursting of that bubble happens to everyone in medicine at some point, but it does enable you to see the world through the eyes of others, to understand others' perspective, and to become more empathic. Empathy is the cornerstone of emotional intelligence. Medical schools select for this characteristic, and it can be developed further through structured support and mentoring, enabling doctors to manage their own emotions, as well as understanding better those of their patients. And I would argue this approach leads to better emotional resilience. To meet this need for support in our medical students, with my colleague Sophie Parkinson, who's now the Director of Student Support at Leicester Medical School, I established the Pastoral Support Unit, or PSU, within Leicester Medical School in 2012. The PSU team in the medical school consists of 3 members of academic staff, 2 of whom are medically qualified, and 1 full-time administrator. It was a deliberate decision that students would be seen by clinicians who do not act in any clinical capacity for the students for 4 reasons. Firstly, they can contextualise the problem and have credibility with medical students as they have been through medical school themselves and work in a clinical environment. Secondly, they can recognise ill health in the students and signpost them appropriately and safely. Thirdly, they understand the intense pressures experienced by medical students and how much more difficult it can be when the student is mentally unwell. And fourthly, they are registered with the General Medical Council and therefore have personal accountability both for the safety of the students and of patients. What do our students present to our pastoral support unit with? Well, you will see that the majority of our students come to PSU with medically diagnosed mental health difficulties, 30% of our student body, and a further 8% with stress-related symptoms. This is similar in all UK medical schools, and indeed in young adults 18 to 24 years, with common mental health disorders increasing from around 23% in 2017 to almost 37% of young people in April 2020 since COVID struck. We are also seeing increasing number of students with family problems and increasing numbers of students with financial hardship. We also see students with course difficulties, exam preparation issues, and these students are supported by our excellent academic support team led by Dr. Jane Burns. The numbers of students seeking support from the PSU has increased. So from about 10% of the population from when PSU was established in 2012, rising to about 30% of all students for 15-16 academic year, and remaining static since then, with about 25 to 30% of students seeking help each year. The average number of contacts per student per year is between 2 and 3 contacts per year. However, for the most complex students, they have had almost and often in excess of 50 contacts per year. In the graduating class of 2018, which was the first year to have a PSU available to them for the full 5 years of the course, almost 80% had had some contact with the PSU team. I'd been working as a consultant community paediatrician for 12 months when our service was approached to take on the follow-up care of children with a diagnosis of epilepsy as a shared care arrangement with a specialist paediatric neurology colleague, because waiting times for their follow-up care had become unacceptably long. It was clearly in the best interest of children and clinical safety to agree to this request, and extra clinics were duly added, on the understanding we would see children more local to their homes and their schools, and that their epilepsy was stable. What transpired was not straightforward. I would regularly arrive to find the encyclopedic notes of these children waiting on my desk at my outpatient clinics. Many of the children's needs were medically complex, often including learning difficulties requiring specialist educational provision. As a general paediatrician, I was trained to treat childhood epilepsy with a single drug where possible. Almost all these children were receiving at least 2 and sometimes 3 or 4 different anticonvulsant medications. So my colleagues and I reassessed these children, reviewed their medication, and considered whether in some cases some of their medications could be stopped, mindful that they also remained under our colleagues' specialist care. A few months later, at our consultants meeting, my colleagues and I took stock and agreed that we had concerns. It seemed that these vulnerable children, who after all were now receiving comprehensive specialist and community medical treatment, were not progressing as expected, with frequent side effects from medication and in some cases deteriorating school performance. We sensed inequity for these children with complex needs, who appeared to be worse off than before. My colleague, who had also recently been appointed as a consultant, had, like me, also observed at first hand the uniquely specialist approach to epilepsy management on the paediatric neurology ward as a trainee. We decided, I have to say with some trepidation, that we should discuss our concerns with our specialist colleague face to face. What we experienced in that meeting was an in-depth tutorial supported by a detailed position paper concerning our colleagues' rationale for childhood epilepsy management to increase our understanding and to change our way of thinking. We came away with that unreferenced paper and were not reassured. I had trained with a colleague who was by now a professor of paediatric epilepsy. I rang them for advice in confidence, sent over the paper, and I was strongly advised to pursue the issue. As a group of community paediatricians, we then met our hospital colleagues to share our concerns. It was, I have to say, a very difficult meeting, and several colleagues were not able or willing to support us or accept our concerns. We don't see the practice you're seeing. It's your concern, your problem, and you need to deal with it. Relationships with our hospital colleagues deteriorated. However, we persisted through a sense of injustice for these children. Why was no one speaking up for them? In future, more children could experience worse outcomes. We had a duty to act, and were willing to put our collective heads above the parapet in the best interests of our patients. We escalated the concern up the line through our Trust's medical director and through formal letters to the hospital trust. But the system is good at defending itself. It took 3 more years, following multiple parent complaints, for an external review to be commissioned. The Department of Health's independent review in 2003 found that Dr. Holton had misdiagnosed 618 cases of epilepsy and put 500 children on incorrect doses or combinations of medication. The review stated that the concerns expressed by the Consultant Community Paediatricians were not given the weight they deserved. Dr. Holton was suspended in 2001 after a series of complaints dating back to 1995. In January 2006, the General Medical Council's Fitness to Practice panel ruled that his professional performance was seriously deficient. He did not return to work in Leicester and retrained in another non-patient facing specialty elsewhere in the UK. A doctor will often be called upon to act as an advocate for their patients and understands the concept of justice as a professional attribute. So in order to instill and nurture in our students the core values of professionalism that are fundamental to the practice of healthcare, there are important educational principles to be considered in order to maximise both its relevance and its effectiveness. It's not just about telling students off when something goes wrong, but using professionalism as a learning opportunity. We tell students you will make mistakes, and that's normal. It's how you respond to them that matters. The teaching of professionalism in medicine then has some key elements that I'd like to talk to you about. So professionalism learning and teaching needs to be in context, it needs to be relevant, and it needs to be practical, using real life examples. We adopt a spiral approach to our teaching, by which I mean that we revisit and we reinforce concepts at different times throughout the course and in different contexts to cement that learning. It's vital that our teaching promotes student reflection, both on positive and on challenging clinical and professional experiences. And we should be modelling the activity, the teaching activity. And in that way, as clinical teachers, we are acting in a mentorship role. We're acting as role models. And like all our teaching, it should be evidence-based, both in terms of content and process. Professor Diana Laureland's conversational framework model, in which dialogue between tutor and student is seen as central to learning, states that for higher level learning, dialogue must take place at both a theoretical and a practical level. Teaching should be narrative, interactive and adaptive, with delivery from paper-based to web-based to simulation modelling. Using Laureland's theoretical model, I introduced interactive professionalism teaching to enhance student understanding of the more complex concepts of professionalism. With colleagues, we used GMC case studies to teach groups of over 200 clinical medical students at one time, using web-based technologies such as Top Hat audience polling and using their own student iPads. It was possible with this approach to create a safe and confidential space in a lecture theatre where students could comment and feedback anonymously and reflect upon their learning in real time. But I wanted to take this one step further, to increase our students' emotional connection to the professionalism teaching in order to shift their thinking, not just from evaluating to actually experiencing. that teaching. With my colleagues, we introduced a novel teaching approach where students observe and discuss clinical scenarios, role played by academic staff in small groups. These scenarios were real examples in the public domain where doctors had experienced challenging, unexpected, or ambiguous situations in the course of their professional practice, and were required to take professional responsibility for critical decisions. We used the facilitated group discussion to gather student feedback, from which we tailored the plenary session, where students observed us as teaching staff in role, be questioned by a colleague to probe their decision making. And that was in order to situate their learning within an ethical and a medical legal context. Here I am on the stand being grilled by my colleague, Dr. Steve Malchichik. My final story is a personal one. Why would I, as an established paediatrician, take a leap into a leadership role in medical education? I didn't have the t-shirt. Yes, I'd enjoyed teaching medical students and trainees throughout my career, but I had no master's in medical education qualification, no previous formal management experience. And to be honest, the risk of failure was high. But reflecting on my career, I recognised a pattern. Key moments where I took an opportunity offered to me to do something different, something interesting, a stretch opportunity, but potentially a risky career move. And I'd like to give you 4 examples of this. So the first was an unadvertised paediatric respiratory fellowship opportunity in Melbourne, Australia, which arose while I was working as a cystic fibrosis fellow at Birmingham Children's Hospital. I kept the letter, which I spotted on my boss's desk, which was the advert for that short notice opportunity. And I would strongly recommend to any trainees in the audience the art of desktop surveillance in order to pick up career opportunities. So I learned new skills in applied research, in asthma research, leading to publication in high impact journals, and in paediatric respiratory diagnostic procedures, such as flexible bronchoscopy you'll see me undertaking here, which I was able to bring back to Leicester to establish a bronchoscopy teaching programme for my fellow paediatric respiratory trainees, with help and in partnership from the Adult Respiratory Service at Glenfield Hospital. But this was before the days of national training numbers and out of programme experiences, and I took the post at very short notice without seeking approval from the postgraduate dean. That meant I had no UK training post to return to. So I took a series of locum posts and attended a number of interviews over several months on my return to the UK before being appointed as a senior registrar in paediatrics in Leicester. The next was a move from hospital-based training to a community paediatric post as a consultant. I was able to use my experience both in Birmingham and Australia in respiratory paediatrics to develop and implement new multi-professional models of care for children with respiratory disease, such as the Children's Community Asthma Service I established in Leicester, Leicestershire and Rutland with my paediatric respiratory nursing and school nursing colleagues. But my credibility as a paediatrician came under scrutiny by my peers, and I was challenged about my decision to move from specialist tertiary practice to what was perceived by some to be a post with lower professional status. My community colleagues were without exception welcoming, but also questioned my motives. I'd had no formal community paediatric experience beyond the minimum 6 months required to complete my paediatric training. So the next opportunity arose in August 2000. And I took up an invitation with support from my trust to become the paediatrician on the tuberculosis outbreak control team, working with colleagues from public health in Leicestershire, East Midlands, at Crown Hills Community College, Evington, Leicester. This was the UK's most serious community outbreak of TB for 20 years, with over 1,100 children screened and 33 confirmed cases of TB. So I acquired valuable new skills in communicable disease outbreak management, quite relevant, I guess, in the current climate, while benefiting from the multidisciplinary expertise, strong collaboration within the team, and with excellent public health leadership in that team. But I was seconded from my Consultant Community Paediatric post for almost 12 months. There was a risk I would become de-skilled. My fourth example I'd like to talk about is motherhood as a doctor. My family is both a joy and a privilege, and it was really true that my credibility as a paediatrician increased with each child I parented. I should point out these aren't all my children. I found that I could now advise parents regarding any aspect of their child's health and well-being, from chilblains to Charcot-Marie tooth disease, with real authenticity, and often based on my own personal experience as a parent, as well as my professional experience as a paediatrician. I have observed a glass ceiling in medicine. While I have personally not experienced any overt discrimination in my professional working life, and I'm delighted to receive professional recognition by the University of Leicester through the award of a chair, I have learnt that there are hidden, largely unconscious factors which can slow women's career progress in medicine despite their competence, even within egalitarian workplaces such as the NHS and in our universities. Gender schemas do operate in medicine, as they do in other professions such as the law and in business. And slower accumulation of advantage resulting from just small differences in the evaluation and treatment of men and women can have cumulative and substantial long-term effects, both in terms of pay and progression and promotion. Each of these four experiences I've described has allowed me to see and experience the bigger picture in medicine. Paediatricians are great generalists. However, as a consultant, I found myself increasingly working in a narrower clinical context. Patient assessments were more protocol driven. It was becoming predictable. I have to say, somewhat routine. I then observed with interest the appointment of a new chief executive in my employing trust who had a medical background, and saw that as a doctor it was possible to influence established organisational systems and challenge and change processes in healthcare. I recognised that I was at yet another career crossroad, and I took a further risk rather than play it safe and continue as I was. My appointment as the Director of Medical Education at Leicestershire Partnership Trust, together with the Leadership Foundation of Higher Education Aurora programme, gave me the experience, credibility and confidence to successfully apply to become the Deputy Head of Leicester Medical School 3 years later. The NHS and university systems are not too different. And I would argue that there are synergies between the qualities and motivations of a paediatrician and of a medical teacher. As with children and their families, in medical education, every contact counts. A chance conversation with a colleague, a teaching session with students, a piece of feedback, a request for advice from a trainee provides opportunity for me as a teacher and a leader in medical education to be curious, to learn from that experience and to look beyond the immediate issue to see the whole. And I hope to play my part in producing not just good, but great doctors. So my summary of what makes a good doctor then is that a good doctor should be curious, should ask good questions, and should be able to see that bigger picture. A good doctor is emotionally intelligent, has good self-awareness, and is empathic. A good doctor is an advocate ensuring justice for their patients. And a good doctor is courageous, is willing to take opportunities and influence the system. Finally, I would like to end in my 2 slides on reflecting on 3 reasons why this subject is so important. Firstly, because patients deserve high quality care from well-trained, competent doctors. Secondly, because reputation and trust in the medical profession must be earned and not taken for granted. And thirdly, because doctor morale and their retention in the NHS is intimately bound up in their personal job satisfaction, autonomy, and through recognition for a job well done. While the 2016 junior doctor strike arose out of a dispute about pay and conditions, it became about all of these things. A collective call to save the NHS from a stretched trainee workforce under pressure, struggling to meet the rising demand, while wanting passionately to provide the best medical care for patients. If we are to retain our young doctors in the profession, we need to take good care of them. Improving the emotional well-being of a medical workforce requires interconnected interventions that consider the individual, the system, and the culture of medicine as a whole. I'd like to finish with the recommendations from Caring for Doctors, Caring for Patients, which was commissioned by the General Medical Council and undertaken by Professor Michael West and Dame Denise Coer. This is summarised as an ABC of doctors' core needs. Firstly, autonomy, to be able to carry out our work in accordance with our professional and personal values. Belonging, looking out for ourselves and for each other, feeling valued, respected and supported. And competence, the confidence that we have to deliver high quality outcomes for patients and to be able to experience their effectiveness. I'd like to thank you all very much for listening. Thank you.
Judith, it's my honour and privilege to thank you for that tour de force. That was a fantastic talk, which summarised to me exactly what makes a good doctor. I feel very lucky to have you as my deputy. You're constantly guiding me and guiding the school. And that talk has summarised exactly why you're providing us with such great advice. I want to take away a few things, and I just want to emphasise a few things, I guess. The importance of empathy, your story about the need as doctors always to think outside the box, not to just simply follow recipes or guidelines, but to stretch our diagnostic skills at all times. The importance as seniors to model for our colleagues and juniors behaviour, to grab opportunities. I know you described how you have, and so many of us describe those opportunities that just pop up every so often, and you grab it and suddenly doors open that you wouldn't otherwise know were there, frankly. Making mistakes is part of normal professional life, and the importance then is how you respond and react to those mistakes, and learning and reflecting on those mistakes is critical to being an excellent doctor. And finally, of course, the need for all of us to look after each other, to look after our junior workforce. They're our future, and that way we'll be a great profession. So, Judith, that was a fantastic talk. I'm sorry that we can't make the noise that would normally happen now to congratulate you on the superb talk that we've listened to. But suffice to say, there's a whole wave of clapping that's just out of hearing range at the moment. But thank you very much, and very well done. Thank you.